Low back pain. So about 90% of us will experience low back pain at some point in our lives. It's a matter of when and uh, and how severe it's going to be. So today I wanted to discuss a specific type of low back pain that is particularly common among women. It's called sacroiliac joint dysfunction or SI joint pain. So what is the SI joint and where is it in the body? So let me get my skeleton. Mr. Bonaparte, Napoleon Bonaparte, sacroiliac joint. Sacrum, ilium, this is the sacral bone, this is ilium, and this is the joint, the place where the two bones meet together. Sacroiliac problem causes anywhere from 15 to 40% of low back pain. And those numbers are significantly higher among women than men, at least 3 times. There are important factors that cause sacroiliac joint dysfunction. Number one is trauma or some kind of injury to that area. So, for example, when patients come in complaining of pain in that area, the number one thing that I ask them is, have you ever fell on your butt? Have you ever been involved in motor vehicle accident? And you'll be surprised how many patients do answer yes to one of those questions. The other common problem that's condition that's associated with this is the joint hypermobility. A lot of individuals are naturally hypermobile. They have joints that are hypermobile, and what that means is they have increased joint laxity. And when you have more movement in your joints, about 10% of the general population have that, you're more prone to developing joint dysfunction. And the reason why is because you have too much movement in those joints. And too much movement means there's lack of stability. In your SI joint, you have these things called ligaments. This represented by this little rubber band, and you have it here, you have it here. Particularly important is something called iliolumbar ligament, sacrotuberous ligament, and they're holding this SI joint in place. They're so strong that you could even lift the entire body by these ligaments. And when in a person who's hypermobile, these are overstretched. They're like a rubber band that has lost its elasticity. And so as a result of that, they're not holding things in place like they should. And the person develops too much movement in that joint. And that puts them at risk for injury, inflammation in that area. And so in a normal person, they could walk, they could sit without any problems. In a hypermobile person, it causes pain or dysfunction. Similarly, think of imbalances or poor posture. Think of scoliosis. A person with scoliosis, which is a very common condition, about 3% of the general population have it. And again, 3-to-1 ratio, women have it a lot more common than men. If you have a little bit of scoliosis, the spine is curving a little bit more to one side than the other. That means excessive amount of tension is placed on the SI joint. And that means one side of the SI joint is going to get more weight, more pressure. And that means one side of the low back is going to get a lot more inflammation. And that's how typically you have SI joint, and typically would affect one side more than the other side. Another very common problem that's associated with this condition is length discrepancy, one leg being longer than the other. The leg-length discrepancy by itself will not cause this condition, but if you're predisposed, or again, if you have some kind of an injury like a fall or a car accident, this will accelerate you developing this problem. And especially if one leg is longer than the other by a significant amount, let's say 2 centimeters or more, then you'll be at a much greater risk of developing it faster, which is the reason why whenever somebody comes into my office and I suspect there's an SI joint problem, I always measure what the length of one leg versus the other. It's a very quick and easy test to do, and it heightens my suspicion for the SI joint if one leg is longer than the other. Diagnosing this condition can be challenging for a number of factors. Sacroiliac dysfunction can have different presentation and does not have a great diagnostic test and requires a keen knowledge of anatomy. Otherwise, your doctor might just say, you have a herniated disc. So, number one, overlapping symptoms. The symptoms of the SI joint dysfunction can be very similar to other conditions, such as any lumbar spine disorders. Think, for example, herniated disc. As I'm showing in the chart here, herniated disc has sometimes exactly the same distribution of pain as the SI joint. So a patient might say, oh, I have pain in my butt radiating down the leg. Well, guess what? It could mean you could have a herniated disc. It could mean you could have an SI joint. It could mean you have a facet joint problem. It could mean you could have a piriformis syndrome. The patient could also come in and say, I could have pain in my groin. Well, if you have pain in your groin, you could have an SI joint problem. It could also mean you could have a hip arthritis. So this is where taking the history and doing a good physical exam is very, very important. Number two is lack of objective test. The difficulty with diagnosing this thing is there is a lack of definitive diagnostic test for SI joint dysfunction. So while imaging techniques like an X-ray, a CAT scan, or an MRI can be helpful in identifying structural abnormalities and in ruling out other conditions, they may not provide conclusive evidence for SI joint dysfunction itself. And so what this means is very often you will do an MRI in a patient and looking specifically at the SI joint, and it looks completely normal. What do you do with this result now? You are convinced that the patient has an SI joint, but the MRI looks completely normal. That does not rule out the fact that they could have an SI joint. There's other steps that you need to take. Patients also could have complex anatomy. The SI joint is a very, very complex structure, and there is evaluation, and its evaluation requires a thorough understanding of its anatomy, biomechanics, and potential variations. An overstretched ligament, for example, does not show up on the MRI. So, as I mentioned before, in a hypermobile person, they have overstretched ligaments that in the structure that does not hold the SI joint in place. You again do an MRI, does not show up on the MRI. Number four, symptom variability. The symptoms of the SI joint, as I mentioned before, could be very varied among different individuals. One patient will come in, it will be only hip pain, and that the SI joint presents as. Another patient, it will only be butt pain that the SI joint, but both are caused by an SI joint dysfunction. And finally, diagnostic injections. Sometimes the only way that you could definitively know whether a person has an SI joint problem is to just go ahead and inject it. It's usually done with lidocaine, which is just simple numbing medication. We do it with an ultrasound or fluoroscopy, which is X-ray guidance. And once you inject, you know right away, is it the cause or not? Because the patient will know if the pain is alleviated or not. And we're looking for at least 50% relief. Really, we're looking for 70+% relief. Now that we've diagnosed the condition, what is the treatment? How do we make this go away finally? And of course, always start with conservative management first. So you do the simple things that work, that are effective. And by that, I mean physical therapy. It's effective. It works with most patients. If you simply use targeted exercises to improve the stability and strength and flexibility of the muscles around the SI joint, so specifically in this area, in the glutes, and then the core muscles, you have a success rate of anywhere from 50 to 70% in this patient group. If you also combine this with a little bit of over-the-counter anti-inflammatories, with some heat, some ice, and with an SI belt. An SI belt is a simple tool. Think of a belt. I'll show you a picture here. It goes all the way around the body. You tighten it up, and it could provide that stability. The patient has that lack of stability, that laxity. It provides that stability for the patient, and it's shown to be very effective. Sometimes it works, sometimes it doesn't work in certain patients, but it's very cheap, and it's very effective. If that doesn't work, then you move on to injections as a next step. And typically the next step is a cortisone or a steroid injection. You have two big systematic meta-analyses that were done in Pain Physician in 2019 and Clinical Journal of Pain in 2020 that showed that these injections provide good short-term relief. Some patients experience complete relief. Some patients experience only partial relief or temporary relief. So overall, it's an okay treatment, is what I would say. But regardless, what the way that most clinicians use it, myself included, is if the physical therapy didn't work, or if you want to accelerate the treatment, you do the steroid injection and you start the physical therapy concurrently. So that gives you a little extra oomph. The next injection that I personally don't do, but a lot of pain management doctors do, is radiofrequency ablation. And what it is basically using a sound wave. You are cutting the nerve that brings the pain signal to the brain. The injection lasts anywhere from 6 months to 2 years and is moderately effective. My favorite injection, and the one that has been time proven for over 70 years, is Prolotherapy and PRP. And what this injection does is basically same as it's an injection that goes to the same area as the steroid, right into the SI joint. Again, it's done typically with ultrasound guidance or fluoroscopy. So contrary to what the steroid does, the goal is to strengthen the ligaments in this area. We want to tighten, we want to thicken up the ligaments that hold the SI joint in place. So we inject it right around the SI joint. We inject the ligament, we inject the joint, and it is shown to be a very, very effective treatment, long-term treatment. Unlike the steroid, it's been shown to make the problem go away and not come back in the future. So in follow-ups of a year, 2 years after the treatment, the problem does not return. This treatment has been around for 70 years and has been shown to be very, very effective. This is my favorite injection to do for this type of a problem. Let me know if you have any questions. Subscribe, like this video. Thank you.